March Health in Hackney. This is the last Health in Hackney of this administration. I've had apologies for absence from Dr. Kathleen Wendon, Dr. Sandra Husbands, Helen Woodland, Councillor August Canley. And can I also just take the opportunity to thank John Williams, who's the Chief Exec of Healthwatch. He's going to be leaving us to start work on the North East London footprint in an engagement role. So congratulations to John on that. He will be very sorely missed, and he's been a regular participant at these meetings over the years. And I think we should note our thanks to John in particular. Just matters of housekeeping, if I can. Hybrid meeting. I've got Laura Sharpe from the Confed, Councillor Snell, Councillor Adams, Councillor Plouviez here in the chambers. I've got other members who you'll be able to see on the screen. Please keep your microphones off, except when you are speaking. Please don't start conversations in the chat. If you'd like to speak, please raise your electronic hand. Members of the press are sometimes watching, so be aware of that. And so I think that covers it all off. Please keep your cameras on, particularly when you're obviously presenting. I haven't been informed of any declarations of interest other than the standard ones which we normally note. And so then with that, I'm going to come on to the main substantive item on the agenda. And we've got nearly an hour and a half of this, which is really to understand the GP picture in Hackney. And we've broken it down, if people look at page 8 of the agenda, into 8 separate areas. My plan is, and we've asked the presenters to, of those 8 different areas, to speak for say 5-6 minutes each. My plan is to do the first 4, opening up for questions, and then do the remaining 4, opening up for questions and discussion, just so it's not we're being spoken to, so that for a long length of time. So the first of those 8 areas, if I can introduce Dr. Kirsten Brown, who's the primary care clinical lead for City and Hackney, and also a partner at the Spring Hill practice and the Lawson practice, and then Richard Bull, who's the program director from the CCG, and basically they're going to give us an overview of how is primary care commissioned nationally and enacted locally, and then Richard's just going to talk us about the 39 practices in Hackney, and hopefully I think one of you can maybe just explain the difference between the different types of contract and what that means. So Kirsten, over to you if we can. I think you may have some slides for us.
Thanks very much. So thank you. My name's Kirsten Brown. I'm a GP in City and Hackney. I've been a GP in City and Hackney for between 16 and 17 years. And as I said, I'm a partner at Spring Hill and Lawson practice, which are 2 large practices, one in the north and one in the south of the borough. And I'm also the primary care clinical lead for City and Hackney, working alongside Richard Bull at the CCG. So I'm going to attempt to share some slides here. So bear with me. Here we go. So can you see those slides?
Yep.
Yep, great. So yes, I've been asked to talk about how primary care is commissioned, which is very complicated, but I'll do my best, and I'm sure others can chip in with more information as we go along. To start with, there's a national contract. And there's one core NHS primary care contract, which is between NHS England and the providers of primary care. And there are 3 different forms of this contract which are similar. So there's GMS, PMS and APMS contracts. The majority of practices across the country, and this is true of Hackney as well, are on GMS contracts. So these are general medical service contracts. We have 8 practices on Hackney on PMS contracts, personal medical services contracts, which are similar. And then we have 5 practices on APMS contracts. And it's worth noting that GMS contracts and PMS contracts are in perpetuity. So providers have them for as long as they have that for essentially for life, unless they decide to give back the contract for a reason, or there is real grave concerns about the quality of the provider and it's taken away. The difference is with the APMS contracts are that they are for a duration of time. So most APMS contracts are 15 years, and then these need to be put out for procurement every 15 years, and providers would need to bid for those contracts and win the contract every 15 years. It's worth noting, as I said, that all new GP contracts are APMS contracts. So NHS England are not giving out new GMS or PMS contracts. So who are providers of our local?
Kirsten, just before you go there, I understand that GMS and PMS are both in perpetuity. Is there any main distinction between the two of them?
No, not anymore. They've been equalised out, and the idea initially, when PMS contracts came into being, which others on the call will know more about, the idea was that they could be more designed more locally and commissioned more locally. But they've been equalised out pretty much now, and PMS contracts are being phased out essentially. But they are very, very similar. Richard, would you add to anything on there?
Yeah, they are very similar now. You're absolutely right. PMS contracts were created to allow local flexibility, but those flexibilities have been taken away over time now. We were told by NHS England to equalise the GMS, PMS contracts in terms of ask and funding, and we did that over a 4-year time period. So now the two contracts are pretty much equal, although the PMS contract status still is there. But PMS practices can opt to become GMS practices, although in reality there's no benefit for doing that because they are essentially the same now.
Yeah,
sorry, I interrupted you, Kirsten.
No, not at all. I mean, I think the APMS contract is the one that's really different because it has, as I said, it's procured for a certain number of years, and the procurement process has to happen every 15 years at the moment. So who are the providers of general practice? Well, the majority of general practice across the country, and this is again true of City and Hackney, are local primary care partnerships. So these are GPs who come together in partners, so 2 or more GPs come together in partnerships to provide GP services. There are 32 in Hackney, but there are also 2 others who have more than one contract. So Richmond Road has a PMS contract at Richmond Road and an APMS contract at Sandringham. And then our practice, the Lawson practice, has a GMS contract at the Lawson practice and also runs Spring Hill APMS contract. Then there are 2 large GP organisations who run practices in City and Hackney. So AT Medics run Trowbridge surgery and Hurley Group run Allerton Road surgery, both on APMS contracts. And these are large GP organisations running lots of practice either across the country or across London. And then finally, the ELF, our local mental health trust, runs our homeless practice, the Greenhouse practice, on the APMS contract. So how does the funding work? So the funding, we can essentially split it into 3 areas. You've got the core contract, which is the capitated sum per patient, and this is set nationally. And to that is applied the Cahill formula, which is quite complicated, but it's to do with your patient's demographics and certain characteristics of your patients to try and make the core contract more equitable. It's worth noting here that that doesn't act in the favour of deprived inner city practices often. So in City and Hackney, our practices often lose out under the Cahill formula because it doesn't take into account those deprivation measures. That much more weighting is towards age and frailty, and as we know, we have a young practice population, a young population, but often a young population who gets sicker younger. Then we have the quality and outcomes frameworks, which are based on reaching outcome standards, such, for example, are patients with hypertension or diabetes reaching certain quality outcome standards, and we get paid additionally for that. And then finally, there are additional services which are commissioned both nationally and locally. Now, the nationally commissioned additional services via NHS England are called direct enhanced services. And our primary care networks, which we'll hear more about later, I'm sure, are commissioned via DES. And then the CCG and local authority via the public health also commission additional services on top of the core contract. And these are called local enhanced services. And the vast majority of Hackney, of our local enhanced services, are commissioned from practices via the City and Hackney GP Confederation. And examples of these may be are long-term conditions, home visiting, anticoagulation, and sexual health, just to name a few. I'm sure, as I said, that other people will be talking about that. So as you can see, it's complicated. I hope that's done something to explain the basics, and I'm sure other people will add to what I've said. I'm going to stop sharing my screen now.
Thanks, Kirsten. That's very helpful. Richard, did you want to add anything at that stage in terms of the overall introduction?
Yes, I was just going to add about the contract management. So we manage the contract on a delegated arrangement on behalf of NHS England. I think Kirsten was going to cover that in the slides, but they were in the presentation, but Kirsten didn't actually speak to that point. Yeah, so we manage the contracts on behalf of NHS England on a delegated footing. That's it, really.
Thank you. And we'll come on. We're going to hear from Dr. Robson a bit later on in terms of sort of KPIs and effectiveness, and it may well be then we've got some questions for you following on from that as well. Thank you. So that gives us a starting point. The next area I'd like to bring in now for the second area, Laura Sharpe, who's the Chief Exec of the Confederation City and Hackney, and Laura's going to tell us what Kirsten's just alluded to as to what does the CCG do on top of the basic contract. So over to you, Laura.
There it is. Got it. Thank you. Sorry. Thank you. Yes. So if that wasn't complicated enough, then we have local arrangements on top of these national arrangements. And in fact, we're one of certainly in North East London, one of the areas with the greatest number of additional services on top of the national services commissioned via the Confederation and delivered at practice level, to the tune of about £10 million extra income per year going into practices, which is not insignificant at all, and is probably about another third on top of their existing national work that practices do for local people. So practices work very hard for this money, but this money allows them to bring in extra staff and provide this wider range of services that is not necessarily available in other areas of the country. For example, one of the contracts that the CCG commissions from the Confederation and the practices deliver is something called proactive care home visiting. And this enables practices to buy in additional resource staffing so that GPs can actually go and visit housebound patients at home, can actually every year organise for those patients to have a medication review, either over the phone or in their home. Now, when I say that to my mum and dad in Stoke-on-Trent, they say the GP comes to the house of very frail elderly patients every quarter or 4 times during the year, depending upon need. And that is a local service that the CCG has chosen to invest in. So with those services come through 2 routes. The first is, I don't know what to call the CCG anymore, but I'll call it the CCG. And there's a whole range of those services, proactive care, as I've mentioned, huge amount of effort on management of long-term conditions, so that we're shifting our services from a reactive service to a much more proactive service where practices look at the people who have a long-term condition, think about when they last saw them, call them in for a review, get them on the phone. So it's a much more proactive model, as opposed to waiting for that person to feel a bit ill and then come to the surgery or ring the surgery. Huge amounts of effort on long-term conditions, and that is paying massive dividends in health gain, which Jon will talk about. We have a due-to-doctor service, so that means if you have an urgent medical need, you can ring your surgery and get a call back within 2 hours. And equally importantly, it means another healthcare professional can speak to your GP in 30 minutes if they want to discuss your case urgently. So if it was a decision between taking you to hospital or not, then a conversation with the GP could make all the difference around that. Again, not a service that's available everywhere in the country. Lots of other services along those lines, as well as some more what you might call pedestrian services that you might assume are funded through the national contract, but in actual fact are not. So if you need to have some bloods taken, many practices in Hackney will do that for you, saves you trekking off to the hospital. That isn't funded through the national contract, so the CCG, because they think that's an important local service that should be available through the front door of a practice, fund it in this way. And then the local authority, who actually started this idea, in all honesty, it was the previous Director of Public Health who said, I don't want to commission with, as it was then, 43 individual practices in this rather haphazard way. I want an intermediate body that organises all of this. And thus the Confederation was formed. London Borough of Hackney Public Health commissioned sexual health services, health checks, NHS health checks, and stop smoking services. And just so that you're aware, our stop smoking service is one of the best in the country. We help 700, the target is 750 people to quit every year, and we pass that target every year. And that's because the GPs now, it's almost second nature to refer people into it, and the service is really responsive. So we've created a really good partnership there. So a whole range of services, some more about prevention, some about more proactive management of care, some about access, all available to City and Hackney registered patients. And as I say, not necessarily in place elsewhere. And that's what NEL is now looking at, because it thinks that some of these services ought to be looked at to be rolled out across the wider NEL footprint, which is good news. So why do this through something called a confederation? Why create it? Well, as I say, I think commissioners would rather talk to one entity than 40. And this also enables us to offer something, I think, which is quite magical, called total population coverage. So in the old days, a practice could choose whether to take on these locally enhanced services. So practice A could say, okay, I'm going to do the duty doctor. And practice B could say, I'm not. And as a patient of practice B, that's not really fair. So what this does is we effectively guarantee low total population coverage. So we say to the practices, if you can't do it, number one, let us help you do it, because first and foremost, we would like this model to be delivered through every surgery. So let us help you, let us come in, let us guide you, let us help you set it up, let us help you recruit the staff. And in the early days, we did a lot of that with practices that had never done this work before. Less so now, everybody does it now. But, or we would say, we will get another practice to do it on your behalf, or we will create some sort of hub and spoke arrangement. So our commitment was that whichever practice you were registered with, you would be able to access these services. And that's quite a significant plus for a confederation, because it means that the residents of Hackney should be less of a lottery, as it were. They should know that all of these services are available in all the practices of Hackney. It's also much easier in terms of the commissioners can talk to us about the contract. We can then translate that into GP language. We then help the practices through constant support and advice and guidance about delivery. We can look on their systems just in the same way that Clinical Effectiveness Group can, and we can say, excuse me, Dr. Colvin, you've got 400 people with diabetes and you've only seen 20 of them this year. Is something going badly wrong here? I've never had to say that to Dr. Colvin, by the way. And then we can either go in and help, or the practice will say, oh yes, we know, we've got it under control, or they might sometimes say, really? Oh my God, what's going on? Help, let's sort it out. So we have a sort of what you in other worlds might call a performance management role, but our practices see it as a support infrastructure. And indeed, we ran a meeting today for all the practices to just remind them about all the contracts starting again. All of these contracts kick in again, full on, from the 1st of April, just taking all the practices through, reminding them of what they needed to do, get ready, we'll be giving you guidance, read the bulletin every week, etc., etc. So I think on the whole, the practices think that we're supporting them. Occasionally they think we're nagging them, and occasionally we have to. But mostly I think it's a support methodology, I hope. And so that was why the Confederation was set up. That was our core function, and still is, in all honesty. That's our biggest staffing structure and biggest focus of attention. But even though I say it myself, we've proven to be quite good at it. So people ask us to do other things on top now. So for example, I'll just give you a couple of live things that are nothing to do with these contractual arrangements, but in conversation with Kirsten and Richard, that we're looking at two things to support practices through the next 12 months. We're looking at a model of protected learning time that allows practices to close for half a day in a particular quarter, to either come together as a team to reflect or to plan new services. Because when you're on the treadmill, you can't think. You need a bit of stop time. So can we plan that in a proper way? Can we give the practices the support they need to use that thinking time to best effect? And something that we're just beginning, which is to create a local, we call it a staff bank register. It's a bit like a dating agency. Nurse A is free on a Tuesday afternoon because she only works 3.5 days a week and would quite like a bit of extra work on a Tuesday afternoon. Practice B is desperate for a bit of extra nurse time. We are creating a mechanism to allow those two to connect, whereby it will be automatic, all the employment checks will be done, the practices can post what they need, the nurse can post when she's available, and hopefully that means that local staff with a bit of extra capacity are utilised in local practices who desperately need a bit of extra capacity. Things like that. We do lots and lots and lots of support the practices to stay strong and resilient. And then finally, we never imagined this would be the case, but we've become a voice for primary care in the system alongside the primary care network, clinical directors, and Kirsten in her commissioning role. So that is quite a good, powerful voice to remind everybody how important general practice and primary care is as we transition into new arrangements and as we lose some of the strength of GPs in a commissioning role at the CCG.
Thank you, Laura. And just to flag with other members sort of some of the things that we can maybe just have when we ask the questions shortly, which Laura's touched upon, is what is the Confeds' role going forward as the sort of the CCG powers have the funding has gone upwards to an NEL level. Will that come back down, and where does the Confed fit in? And also, how does the Confed fit in with the primary care networks, which we're going to hear about a bit later on, and how do they interact? So that's possibly some areas for discussion. Can I now go, so 2 more areas, 3 and 4, and then we'll open up to questions at this point. So 3, we're going to hear from Dr. Deborah Colvin on the provider landscape, but essentially the partnership model. We've heard 32 of the 39 practices are partnerships. And maybe Deborah, you can just talk about some of the pros and cons of that arrangement from your perspective.
Thanks. So if I talk about the provider landscape first, and I took this to mean what it looks like to partnerships at the moment. So I can say in a word, it's very turbulent and very rocky. And there are a fair few reasons for this. So I think the first thing is that post-COVID, primary care, just like secondary care, is incredibly busy. 2 years of a lot of patients not going to see the doctor has increased sickness levels. It's been more difficult to deal with long-term conditions because we've had patients that, I had a patient die very recently. He would not come and see me because he was so frightened of going out, and he had multiple serious long-term conditions that needed looking after. And I think he died because he was too frightened to come and have his conditions monitored, which is really sad. So lots of long-term condition illness, lots of other illness that's been hiding. A huge increase in mental health problems, and this is not the sort of mental health that you refer to a psychiatrist. This is much more general practice mental health, and we can't find people to help us work on this because there aren't the people around to recruit to help us with this. But also lots of work from the hospitals. I think because they've been having to manage in their way, they have got used to being able to say to us, look, I'm going to see this patient again in a year. In the meantime, can you do this, that, and the other? Can you monitor this? Can you check them up in 3 months' time, 6 months' time, do some more blood, blah, blah, blah. It's a lot of work. It's a huge amount of work that we're doing on their behalf for understandable reasons, but it does also contribute to our difficulties. So it's much busier. We've got a growing population in Hackney of very sick people, lots more babies. We've got a huge problem with workforce, which I'm sure you all know about. But the number of GPs is dropping. You can't find nurses. It's very hard to recruit reception and admin staff. Partly because the pay scales in primary care haven't sort of kept up with other parts of the system. So secondary care has had a bigger uplift than we have, and we can't pay the same sorts of rates, which often makes it hard to recruit people. We've got quite a lot of GPs who are choosing to go into locum work because it pays well and it's much less stressful. That's really, really difficult. So that's pushing up the cost of employing our salary GPs because we desperately need to keep them. But it also is very sadly means there's a whole bunch of GPs out there who have no continuity with patients. They don't see nearly as many of them face to face. And I can see that very able and well-trained doctors are losing the skills of general practice because you learn and you hone your skills by seeing what happens to people. And this is, I think, really very, very serious. And one of the huge dangers of everybody thinking we can move to a digital world where nobody sees people. We're going to become very bad at doing our job if we're not careful and not much use to people, which is heartbreaking. Another big problem is estates. We're all running out of space. And I think one of the successes of the Confederation has meant that we do so much more anyway, that we're full to the brim. And now with the PCNs, which are supposed to bring in more help to us, it's really hard to know where we're going to put these people because we're all full up. So where do we put them? And we don't have money to find extra premises for them. So I think the other things for me that make the outlook very sad are, I don't know how many of you have seen the new policy exchange document called At Your Service, looking at the future of general practice. I find it truly, truly sad. It's all about getting people to ring call centres, often ringing doctors from abroad. I understand they're saying, well, that will bring in more doctor time, but at what cost? What's going to happen to people who ring a doctor in a foreign country who doesn't know how the systems work, who doesn't know what services are available, has never met this patient before, will never meet them again, can't see them? So it's about that, it's about video calls, but actually, good medicine, you have to see somebody and examine them. And even through looking at the aftermath of COVID, seeing people and reading what the doctor has understood they thought they were dealing with, and then actually seeing the patient, they're thinking, oh my God, they got this completely wrong. It wasn't their fault. It was actually to see people, listen to their chest, feel their stomach, feel their skin. How do you make a proper diagnosis if you don't use your clinical skills? So that's quite sad and worries me. And I also worry enormously that this whole idea of this wonderful digital world cuts out all our most vulnerable patients. And even with the present systems we're using, the push to get more people on computers and using apps to access healthcare, a lot of my core patients cannot do that. You know, I've got a patient relatively young in her early 60s who's had major physical problems that she can't use a mobile phone, she can't swipe, she can't use a computer keyboard. What's going to happen to her when patients aren't allowed to ring up their GP and talk to them? And we're being, you know, at the moment, we're being told we have to have increasingly high percentages of our appointments available online. The savvy people snap them up. Where does that leave the people that I really care about? And of course, I care about other people, but I do care about the people who are most in need of my help. That's what I'm here for. So I have worries. I have big worries about the future. So just a little bit about the partnership model. I think it's invaluable, and I think that's because of the continuity of care. And there is good evidence now. Nobody can refute the fact that continuity of care saves lives and it saves resources. And I don't know why we want to throw it away. And you won't get it without stable models of general practice where people have some autonomy and some feeling of ownership. Partners have a vested interest in making sure the service works. And you know, when I talked to salaried doctors who've worked in huge organisations that work across the country, for some of these APMS organisations, it's a very different world, and they don't feel valued in the same way. As a partner, you have a responsibility. The buck stops with you, so you have to make sure things are working. You can't say, "Oh, that's management's fault." It's our fault. We have to make it work. And because we care, and because it's our partnership, we put vast amounts of work, unseen work, into the practice. We spend hours and hours and hours. I'm sure all the GP partners here on this call would agree with me. We don't work an 8-hour day. We work a 12-hour day, and sometimes we do that 5 days a week. And often, you know, when I see people carping on about part-time GPs, I'm thinking those part-time GPs are actually working what for everyone else is a normal working week. If you've got small children, you can't always work a 60-hour week. It's quite tiring, actually. We're very nimble. We can adapt. We can innovate. We can do stuff so quickly. And if you saw how quickly we started to work out how to cope with COVID and how to manage stuff, you can't get that with bigger organisations. It's just much more difficult. Can it continue? I'm not sure if it's going to continue if we can't get new partners. And unless we make it more attractive, we're not going to get new partners. We can't. It's hard to recruit them. We're doing our best, but it is a hard thing. There are definitely some disadvantages to the partnership model and the GMS model. At the moment, it's incredibly hard to do anything if the partnership isn't up to scratch. And they can get away with offering pretty, not very good services, but not so bad anyone's going to do something about it, you know, for the whole of their lifetime. And that's very sad. I don't think that's fair to patients. I think we should all be striving to do our best. So that is a problem. And I think that there's also a problem that I think other parts of the NHS find it very hard to understand partnerships. They always say, well, you're private, you're a private contractor. Yeah, we are, but we're working to a national contract that we get paid a set amount for, and actually we are part of the NHS. We absolutely are, and that's what we're committed to. So I don't think I need to say any more at the moment.
That's fascinating. Thank you, Dr. Colvin. That's really fascinating. Before we go open to the questions, then, can we now have the last area for this segment, which is in terms of primary care networks? Now, Kathleen Wendon, who is the current lead of the PCN directors, has given her apologies, but we're joined by 2 or 3 others on the call Dr. Ellie Jacob from the Hackney Downs, I think Hareen Patel from Hackney Marshes, and Vinay Patel from Woodbury and Springfield. And there's a presentation in the pack between 13 and 23. Ellie, are you going to, thank you, I see that. So Ellie, over to you. And also if you can throw in an explanation as to how the PCNs differ from neighbourhoods, just to give us, just to paint that picture for us, that'll be great. Thank you.
Yeah, hopefully that is briefly on our slides. Yeah, so hi, my name's Ellie Jacob. I'm the clinical director for Hackney Downs and also a GP partner in the Nightingale practice. Shall I share my slides then?
Yes, please.
Someone doing that for me, I'll do it myself, yeah. So yeah, Kathleen unfortunately couldn't come for personal reasons. We don't really have a lead clinical director as such. There's eight primary care networks, and then we come together once a month for a monthly board meeting with all 8 primary care networks, and we have something called the Office of PCNs, where we have an operations director, but that post has been absent, and our new operations director starts on the 1st of April. So we've been sort of rotating the chair between us. So Kathleen was chair at the April board, and I'm chair at the next board. So I will, yeah, I can take over from here. So let me just share this, hopefully. Can everyone see that?
Not yet, we can't.
No, okay, a minute.
We have all got the presentation in the pack. So
Let me just
if it's
now. So yeah, I have done.
yes.
Yeah. Okay. Great.
Over to you.
So yeah, I have done. It should be just 5 minutes, just a quick run through. So I think the question is, what are PCNs and what do they do? So yeah, so there's eight PCNs. This is all of us together. So primary care networks is a quite a new thing. It was established just over, well, coming up 3 years now. It was established in 2019, and the idea is it's groups of local practices working together, and at the scale of around 30 to 50,000 patients per network. It's an enhanced service, as was mentioned earlier. It's a DES, so it was optional. However, most UK practices and all of the practices in Hackney signed up to it. So every single practice is part of a primary care network in Hackney. The idea of it is really to work at scale in this number. So we can share staff and collaborate, but hopefully also maintain the independence of the individual practices within the networks. So we can deliver network-based services and additional roles, which I'll come on to in a second. It should also be a platform to sort of work at a place-based sense in the terms of collaborating with, say, community pharmacists and mental health. And again, I'll talk about that in a second. So each primary care network has a clinical director who's responsible for delivering the contract and a network agreement. And each primary care network will meet once a month with representatives from each of the practices, normally a practice manager and a GP. So yeah, in Hackney, here's our map of Hackney. So we've got 8 PCNs, Shoreditch Park in the City, London Fields, Wells Street Common, Hackney Marshes, Hackney Downs, Clissold Park, Woodbury Wetlands and Springfield Park. Now these were, we already had a pre-existing neighbourhood model which had been running for a couple of years before this, which was looking at place-based care and setting up various different services around these areas. So when primary care networks came up, these were matched to the pre-existing neighbourhoods, which hopefully fit in nicely with working together with neighbourhoods. So neighbourhoods have been responsible for organising things like other community services, mental health services, district nursing services, and yeah, we are working closely with them and with the Confederation and with the CCG to develop and sort of align various objectives. And also it can align with voluntary sector, so and residents in those areas. I'm not sure what the example that Kathleen was going to mention there, so apologies about that. in terms of what we deliver as the PCN, in terms of the contract, there's various service specifications, which I've got on another slide. I won't go into detail on them. There's something called the IIF, which is clinical targets. I think Kirsten mentioned earlier QoF. So for those that know QoF, this is sort of QoF for PCN. So we have certain targets that we have to achieve, and there's sort of payment per targets. So that's things like a flu. There's also various prescribing targets. So the idea is really that, so you have to get performance across the PCN, and every practice will then have to reach those, or together you'll have to reach those targets in order to get those IF payments. I haven't got a specific slide on how we're funded, but there's various different funding streams. Essentially, is per patient. There's additional funding for meeting the targets, and then there's a budget for the Rs roles, which if we don't have them in place, we don't get the funding. But if we employ these additional roles, we then get reimbursed for it, and the clinical director's salary. And there's a few other little bits and bobs of funding that sometimes come in for certain things. So yeah, other things. I mean, the COVID vaccination was given to PCNs. So initially, the Confed managed that for the PCNs, and then that was taken over by us. I think last July time, and then extended access. So enhanced access, which is the new out of hours service that will be coming soon as well. So yeah, one of the main parts of the PCNs is this increased amount of sort of roles, additional roles, which additional meaning anything that isn't a GP or a nurse, essentially. So other allied health professionals that are employed by a PCN, and in a way that we wouldn't be able to employ, say, a pharmacist or a physio for one practice, but across a network, you can employ these roles, and these are funded outside of the practice budget. So, and this has been really successful pretty much in Hackney so far. I mean, every PCN has at least one or two physios, pharmacists, social prescribers, and some of these are contracts that's got negotiated on the sort of ×8 level, as in with all networks. But then some of them are individual and flexible for each PCN. So, one PCN may have more nurse associates. I know some PCNs have physicians associates, some have dietitians, and so you can sort of decide in your PCN what is needed. So these are some of the, I said I won't go into details of this, but this is kind of the stuff in the core contract that we need to specifically look at, so that various areas that are a focus for PCNs, like cancer diagnosis. There's then other bits of work on care homes and inequalities, and these are kind of growing year on year in terms of our involvement and input into these areas. And yeah, enhanced access. This has just come out in the contract 2 weeks ago, and so again, this is in development. We will need to be providing, as a PCN, enhanced access from evenings and Saturdays 9 till 5 from October. So this is in development, and a plan has to be put together by July. And this will be a mix of Rs roles, doctors and nurses, and the details are sort of being thought out now how this will work. Yeah, and a word. I guess a word on challenges. I think we felt it was important to highlight there's some of the challenges that we face as PCNs. I mean, probably the biggest one being estates, as was already mentioned. Even if we want to employ some of these Rs roles, we just don't physically have the space to put them, and that this is an issue throughout all of the practices and PCNs in Hackney. In my PCN, we'd really love to have nurse associates, but we just don't have the clinical rooms. We might have a clinical room, half a day a week here and half a day a week there, and it's a real barrier to be able to recruit, and that's a massive challenge for us with practices that are kind of bursting at the seams, even with a mix of remote working. So we ended up employing roles that can work remotely, things that are telephone based, and so we're a bit limited there. And workforce, yes, I mean the R's roles. I can't share that now. Is that unshared? Yeah, great. Yeah, and R's roles recruitment, again, in some areas it's easy, in some areas it's more difficult. And so we have a budget, and if it's not spent, that money doesn't come to us. It just kind of gets lost back into the systems. We really want to be able to support our practices and with all these R's roles. But yes, we don't often have the space, and sometimes we try and recruit and we just can't recruit because this is a national thing, and all of a sudden there's so many jobs out there, and there's probably not enough of these R's roles about, particularly things like nurse associate, physician associate, those kind of roles. Paramedics, we've had a real problem. We'd love to have a paramedic in every PCN, but we've not been able to recruit them. So I hope that is sort of a good enough overview. And
yeah, that's very helpful. Thank you. So in other words, in my head, I'm sort of breaking it down towards two functions. One, you've sort of got a performance management function to lift up, meet the KPIs, and you've got to drive that. And then there's another element whereby you can, if you can find the staff, you can employ these other groups of people in an area on a sort of PCN network to offer more at that level. Is sort of in my head is how I've sort of.
Yeah, and I think actually what I haven't mentioned is what Laura mentioned as well about the kind of being the voice for primary care, and I think I realised that after I got in the post how much actually that is really quite a key role of the clinical directors and the primary care networks in terms of representing primary care in Hackney at those various boards and where decisions are being made. So that's another function, obviously, the clinical directors. But yeah, those are the sort of key areas. And also, yeah, just kind of the network model, the place-based model, and just collaborating with the neighbourhoods, trying to kind of form kind of cohesive place-based care with key, named social workers, named district nurses, and working together across disciplines better, I think, is a key part of primary care networks as well.
Thank you. Now, I've got a whole series of questions I could ask, but let me throw it open to members. Cllr Snell.
I think it's fair to say this Scrutiny Commission has always been very impressed with the work done by the Confederation. I may just mention in passing, when we were looking at end-of-life care and end-of-life plans, and the way in which the Confederation was monitoring people signing their patients up to, I think it's the CMS system, is it called? And actually picking up the GPs who were falling behind and speaking to them and making them do it properly. I am slightly concerned, quite honestly, that the PMS could undermine an existing role to make sure we do pick up the laggards, we do help them produce services of the standards that the best provide. I mean, for example, with the work I was doing helping at the vaccine centres, I would say to people, you ring up your doctor every morning and it's part of their contract that they get back to you the same day. And various people were saying to me, I'm not sure that really happens. So I wonder if it is not time that the stuff that's covered by the Confed contract, we don't pull out the key things that are expected of every GP, some fairly short, accessible list. I've said this before to Healthwatch Hackney, and then actually do some, well, number one, so every patient knows what they're supposed to be getting, and they can be their own quality improvement workforce. Number two, Healthwatch Hackney can go and interrogate it and do some mystery shopping. But also number three, with the PCNs being developed, so actually they don't go off on their own way, and some of those basic expectations that we have about doing end of life pathways, agreeing those with patients, about being able to phone your doctor and get someone call you back the same day, those things aren't lost with 8 different areas going separate ways. I mean, it seems to me there's a real worry, but we do need to hold on to what we've got at the moment. Can I throw another couple of questions in while I'm on it? Okay, the quick one, I was interested in what Deborah said. I didn't fully understand what general practice mental health support was. So I'd like just a very quick explanation of exactly what that is that there's huge demand for as we go back to normal things. And then the final question I was going to ask is, my sister is a first responder up in Cumbria. I wondered whether there is a role for expanding volunteers to take on the role as first point of reference if we're short of paramedics.
Thank you. I mean, can I ask, just on Councillor Snell's sort of first point about the, with 8 different PCNs, different quality of service, whereas the Confed has managed, because it's across the piece, has managed to create uniformity and a single approach. I don't know whether either Eleanor or Vinny, I mean, what's the risk here that we have 8 different standards going across? I mean, does the Confed have a role in helping you maintain quality of care, consistency across?
Hi. Sorry. Yeah. I mean, I can see your point. I mean, I think we certainly feel that runs parallel. And I don't. As a GP partner as well as PCN clinical director. I mean, all of those Confed contracts are still completely essential and valued. And so in terms, there's no, hopefully no risk of those going, and they run parallel. I suppose where it might change is if things are then get taken over. So if the if the sort of NHS England decide that certain things are now coming through PCNs instead of Confed, I suppose things like flu vaccination, which didn't come through Confed actually before, but it may be that those things start channeling through. Then I think you're right. We work across networks rather than the Confed aren't involved in managing our IIF targets. So I think that's a really valid point, and I don't think it's a problem now, but potentially it might be more as more things are coming through. I think that's the kind of function of the office of PCNs and us getting together. And we have, if our operations director will be monitoring the progress of all of our IIF. And so just regarding the paramedic and the first response, we have quite a defined list of roles. So it has to be, a paramedic. So sometimes we would like a slightly different role, but we can't. It has to be on this specific defined list of ours roles that we're allowed to recruit. So we can sometimes, it would have to be a paramedic for that. But yeah, Vinay, I don't know if you had anything you wanted to say something else on that.
Yeah, so I mean, broadly the agendas are quite different. So the Confed aren't, managing our contracts, and it's 2 different work streams really. But it's difficult as the PCNs. I mean, one thing that we need to celebrate, actually, I think you were talking about 8 PCNs going in different directions. We need to celebrate the fact that very early on, we realised that we needed to work together for the benefit of City and Hackney. We've always had very strong primary care in City and Hackney, as evidenced by the people on this screen that have talked today. So we realised 2.5 years ago that we needed to keep that up. So as 8 PCNs, we've communicated regularly throughout with formal board meetings and lots of communication in between, and also communicating with our neighbourhoods team. We've realised that we need to improve the relationship with the Confederation in terms of working together. So maybe there is scope for us to be closer aligned to our priorities and have that Confederation help us, not necessarily set targets for us, but help us achieve our joint targets for the benefits of the health of our residents in City and Hackney. The other thing, I mean, I'm LMC chair as well. I mean, I heard the passion in what you were saying there, and capacity is a huge problem for us in primary care. So you're talking about patients not getting a call back the same day. None of us want to be offering that type of service to patients. We don't want to be letting our patients down or receiving complaints or have people have their health problems not answered, but we're having really, really big problems in general practice. There are not enough GPs, despite government promises. Plans are going ahead with extended hours and all sorts of other things on the promise of additional GPs, which have not been found. We've then decided to employ additional staff through additional roles. Some practices have innovated and got their own pharmacists or paramedics to help out. So we're diversifying the workforce. But the rhetoric is always, you need your GP, you need your GP to call you every day. Now we can do everything, we can do everything, but we can't do everything. There isn't enough of us and we don't have enough time. And equally, we're not always the best people at certain things, certain maybe mental health issues or physiotherapy issues. We're not always the best people and we're not always the most appropriate. I think Yogi is going to talk later about the community pharmacy service. So we really need to try and help patients understand what general practitioners do and what our other healthcare staff do in City and Hackney that work for our practices and also work in the community. That's the challenge for us at the moment, and that feeds into the variation in service provision across City and Hackney, across any parameters, whether it's the Confederation targets, whether it's calling people back the same day, whether it's PCN targets, Healthwatch questionnaires, national patient surveys, any of those parameters. It's all about capacity, whereas everything seems to be focused on access for patients, broadening access. It doesn't work unless we address the capacity issues.
I mean, what about? I mean, I think I did hear on previous occasions sort of how the CCG maybe had offered top up money to incentivise and recruit sort of newly qualified GPs to come into the into the borough. I think that was a few years ago. I don't know whether that's still good. I mean, what about that sort of framework whereby you all club together, or however that works, to have a bespoke hack? I know then other areas could do the same, and then you're all competing against each other again. But is any thought going onto that in terms of extra recruitment?
I mean, that's a fantastic service. My practice has benefited from that. I don't know if Laura wants to come in, but my understanding is it's difficult to get GPs to sign up for it for the last year at least. Deborah touched on this before. GPs are overworked at the moment. They're undervalued. They're feeling a lack of love for the job, perhaps in certain areas. They're not committing to practices and salaried positions. They're favouring more lucrative ad hoc work to reduce the stress of the day. GPs are suffering in their health, their well-being, their relationships. They're reducing their hours. They're reducing their commitment, reducing their stress, and that's perpetuating this whole issue. And we're seeing that you're absolutely right. The Confed scheme is fantastic, and it allows for the GP not only to work in a practice, but also to spend, I think it's one session a week doing a specialty. So we've had a GP that worked on dermatology one day a week, which, you know, really motivates you in your career and is a really supportive thing that the Confederation introduced for young GPs in their career. But we can't find them right now.
Good. I've got lots of hands speaking, and I want to bring other people in as well on the presentation. Malcolm, what I'm going to do is I'm going to take you when you do your when you come to your presentation. So I've got to get through a few people. Can I just, before I go, so I've seen Kristen, I've got Mark, I've seen Laura's hand as well, and I've got Cllr Plouviez. Can I just, before I just go through it very quickly on the estates issue? I mean, this is clearly an area whereby the council can possibly assist in terms of regeneration or build new developments. Obviously, Lower Clapton's possibly going to where the Clapton's Girls' School is. But obviously, I think historically there have always been challenges there. Say GPs wanting to say give up a premises that they may own, or and then you get into quite a difficulty. I mean, are you in a position to sort of like, as PCNs, to come to the? I mean, if you came to the council with a plan, I mean, it would almost need you just, I guess, to show some degree of willingness that you'd got your ducks in a row first to actually come and say, can you help us? We're committed. We want to move. And then there may be greater scope for discussion there. I don't know. Is that something which you're exploring?
What would need to be in the plan? How far would we need to get down to?
All I'm saying is, I mean, Councillor Kennedy might know more than me, but I think on previous conversations, I think there have been instances where it's been mooted, but then say actually realises that the owner of a practice or a GP might not actually want to give up where they've got. I mean, it's clearly an area where I think greater conversations could be had. But I don't know whether that's maybe something that could be explored a bit more, because clearly there's significant estates in the council that could possibly work. Councillor Kennedy, do you want to say anything there?
I can see Richard's put his hand up. It's taken us
a really long time, and it's been a hard but very well worked out piece of work to get the Lower Clapton practice into the Portico building and Spring Hill onto Belfast Road, and to get those through planning. One of the main movers and shakers of that actually was Dr. Deborah Colvin, who's on this call, who came to planning and spoke very eloquently at planning. But Richard will know more about how long that had been in the plan, but way before I took over the portfolio, a lot of work had already been going on. It's a long process, but I know within the system, looking at the whole estates project is something people do think about in the long term. And when you're looking at sites like St Leonard's, when we're looking at Somerford Grove, people are already talking and planning and working out how you increase your GP estate capacity in the borough.
Thank you, Councillor Kennedy. Right, I want to whip round. I thought Kirsten first, and then I'm going to come to Councillor Plouviez in a minute. Kirsten.
Thank you. I just wanted to address some of the issues around access that we've talked about. And, you know, there is a massive focus on GP access to a GP, and that's, you know, in the press all the time. And it is really important. But I would, maybe this is controversial, but I would say that the focus on fast, convenient access as the main focus is not where our priority should be. We have to accept that some people's need is greater than others. We need to accept that, as Deborah was talking about, that the digital, the push on digital has created an inequality of access, and we are at risk of creating a digital inverse care law, where those that can access digitally quickly are using that, and those that maybe need it more aren't being able to access it. So I think we need to reframe it slightly and make sure that there's equality of access, that people that need care the most are able to get the care the most, that there is continuity of care, that patients are able to see their own GP, and we know that is safe, we know that provides the best care. And that, I think, is what's getting lost in the argument around access, not the arguments, the discussions, I should say, around access, is this focus on fast convenient, which is important, but there's also a really need an emphasis on continuity and ensuring we're not creating inequalities in the way we're providing access. So
I want to come back to that point. Kristen, I want to come back to that point. I can in a minute. Can I just take Laura on now, because he wanted to come back in, and then I'll go to Mark, and then I'll just come back onto that inequality.
Thank you, Chair. I just want to come back to Councillor Snell's challenging question, really, about strategic positioning of primary care, in actual fact, and the risk of us ending up with 3 or 4 fragmented functions around primary care: the CCG, the Confederation, the PCNs, the LMC, and how we have to be really careful, and it's your challenge is a correct one, to make sure that we pull those strands together, that we don't duplicate, that we don't fragment, that we don't weaken primary care through that almost by accident. So I think that's a really good challenge back to us, and we should pick that up and think quite carefully about that.
Mark?
Yeah, thanks, Ben. I just wanted to maybe just put a bit of data out there about GP numbers. And obviously, we've talked about and already received some challenges about access. And we've heard about there are other ways of consulting with other healthcare professionals and via telephone and online offers, etc. But nonetheless, I think we would all agree there's a fundamental need for GPs, and Kirsten's just described some of the fundamental reasons for that. If you look at the amount of investments gone into primary care over the years has gradually mounted up by different work that we've been hearing about. It is being spent on extra staff. So if you were to look at and I've just brought up the figures, if you aggregate, I mean, quite a lot of GPs might be part-time, but if you take 2 50% ones, you get a full-time equivalent. A full-time equivalent GP in City and Hackney has 1,550 roughly patients per full-time equivalent GP. That's the sort of number of patients who would be, that's the ratio. You want to get that number down as much as you possibly can. And I remember when I first started working in City and Hackney, that's what one of the key things I wanted to see happen in the Nightingale where I originally joined, and then more widely across the field. If you look at that figure, say Barking and Dagenham, which also has deprivation and enhanced areas of need. It's more of a mixed borough than City and Hackney, but nonetheless, that ratio is 2,450. You know, that's about 900 patients more per whole-time, full-time GP than in City and Hackney. So it's not a competition. I mean, now I as you know, spend more time working across the NEL patch and in the City and Hackney patch still. That's an ambition to get those numbers down everywhere, because clearly that's an important thing to happen. And although it's really hard to recruit GPs, City and Hackney has been successful, and part of that is because many of the colleagues on this call work in training practices where doctors who come out of hospital get trained to take on the role of being a GP. 50% of the practices in City and Hackney train doctors. And when you train a doctor, you're more likely to have that person want to stay with you. Not all of them, far from it. Lots of them stay for a bit, then leave and go elsewhere. But it does help in the recruitment. But despite all that, we're still hearing about access and challenge, which of course we need to do our best to continue to address. But I just wanted to kind of put that bit of context with some of those figures into the discussion.
Thanks, Mark. Councillor Plouviez.
Thank you. I really just wanted to understand a bit more about how these additional roles, how they kind of fit in. You've got, so
microphone on. Sorry, Councillor. Oh, sorry, I didn't see it.
I've got the microphone. So the page with the additional roles on it, you know, I kind of know what some of these people do, but how if they're employed by the PCN, how are they how do they fit? How do they work? How are they managed? How are they supported? Do they go from one GP practice to another? Are they and because there are similar, some GPs may employ their own, and then presumably they would manage their own ones. But how does that work with the PCN? And how, I mean, we're talking about GP time. You must spend so much time in meetings because there's so many organisations, there's so many boards, there's so much communication to have. Is that? And then you've also got to manage all these staff. I mean, I'm amazed GPs ever get to see patients at all with all this going on. Sorry, bad me.
It's our families we don't see.
Yeah, I don't know. I mean, obviously that's my slide with all the my little slide with all the R's roles, so I can answer that. It's like everything. It's not a one model. It's a very varied model of these R's roles, and for every single role is different in terms of how they're employed and who employs them and who supervises them. So because although they're reimbursed through the PCN, actually the employer can be different people. So for example, physios are employed by the Homerton, and then the Homerton we have a contract as a PCN with the Homerton. So the Homerton and those physios work part-time for our PCN in our practices, and they also work part-time in the locomotor service at St Leonard's. So they'll do a couple of days a week at St Leonard's doing normal St Leonard's physio work, and they'll do a couple of days in our practices. And then they have supervision and training through the Homerton. So that's one model. We also then have a model of practices, kind of lead practices employing and organising it through the PCN ourselves. So pharmacists work in that way. So we employ a pharmacist. So when generally things like pharmacists, we probably have several per PCN. So in my PCN, we have 7 practices. We've got the most amount of practices because we've got quite a few smaller practices. And we have, say, four pharmacists who might work across a couple of practices, and they will have, a GP. Well, they have a lead pharmacist supervision, they have a GP supervision, and then they have, some group meetings as well. So some of those other roles that are kind of newer roles, things like nurse associate, and that is it's sort of between an HCA, a healthcare assistant, and a nurse. And nurse associates is quite a new role, and they will be able to do nursing duties such as smear tests and things under supervision of a practice nurse. So that and then physicians associates are kind of similar. They're trained to see patients under the supervision of a GP. So it's a very mixed model. We also have health and wellbeing coaches and social prescribers that are employed by external agencies. Shoreditch Trust employ and supervise. So it's a completely sort of mixed model, really, depending on which role you have.
Thank you, Eleanor. I think I want to bring in a moment Dr. Robson and move on to sort of the next lot of presentations. Can I just make a comment just on what Kirsten was talking about in terms of the inequality? I mean, I think it's something we see all the time as councillors. Probably the most casework we get through is in terms of those on the wrong side of the digital divide having access. Not digitally enabled, can't do it. And I suppose it's a frustration, isn't there? Is there a role here either for the Confed or for the PCNs going forward to work out a system? I know you're dealing with different partnerships, it's got different models, that somehow enables that cohort who are in need to actually be able to get through and get that same day appointment on the telephone, or however they want to be able to communicate, and so that they're not left behind. I think we're constantly seeing, and I get feedback from other councillors as well, about how they're finding the system inaccessible. And as Kirsten was saying, I think that's probably the priority group in a way, the far more vulnerable elderly who can't use it, who probably need it more. And so I still think, and I've raised this with Mark, I think before, I still think there's got to be more that can be done on a borough-wide thing about an advisory process or some sort of guidance that people are working towards to make sure people aren't falling through that gap. But if I just leave it there, because I do want as a comment. Councillor Gregory, I see your hand there. I've got Dep Dir Public Health. I need to get on to the next presentation, otherwise we're going to massively overrun. So I'll try and bring other people back in later on. So can I now go to Dr. Robson to talk in terms of quality effectiveness from Queen Mary University? Dr. Robson.
Hi, thanks very much. Can you hear me all right?
Yes.
Good. So I'm Jon Robson. I'm a GP by background. I worked in East London for more than 30 years. I work across the whole of the ICS in the 7 CCGs, as well as across London now, and I've also worked nationally. So I've got a good view of kind of quality improvement locally and nationally. I can tell you that City and Hackney is at the very top of the kind of tree of innovation, engagement and achievement in terms of quality improvement and impact. It has been really an exceptional kind of achievement. And if you could bottle that elixir of a healthier life, I can tell you sell it for a great deal of money. So, it's a fantastic group of people that you've got around you. I lead the clinical effectiveness group, which is based at Cllr, a staff of about 30 people. We've got data analysts that take the data from GP computing and feed it back to practices and CCGs to show how people are doing. We run searches so that you could identify people who are not on the right treatment and you need to be called in. And we support all the sort of enhanced services that Eleanor was talking about, the PCNs and the kind of various sort of IIF and other services and so on. So that's what I spend my life doing at the moment. But I want to talk about broader sort of clinical effectiveness, and I'll just see if I can show my screen. That isn't what I want to show. Let me just try that again and show a window, right. Gosh. Where's my, let me just, I can't see where my, okay. Let me try that again. Do that.
We do have your presentation, John, if that helps.
Is there somebody else that could show it for me?
Possibly. We might try and work on that. We've got it in front of us on paper.
That's a
So
shame.
do you want to, I mean, how do we measure effectiveness?
Let me just try once more, and then, oh gosh, it's just, no, let me just, all right. Is that showing up now as a PowerPoint?
Not yet. It sometimes takes a minute. No. Yes. We'll go.
Okay. Yeah, that's showing up as a PowerPoint, is it?
Yep. Got it.
Okay. I'll see if I can make the slideshow work. So, I'm talking about how do we measure effectiveness, and so one of the big issues that whatever it is, we need to measure it. So GPs need to record it. And they record on data entry templates that we've been supporting, so the standard measuring, but you need to choose the right method and you need to assess the impact. You have to evaluate what you're doing. So this is showing you the control of hypertension in London. These are all the practices in London. On the left-hand side is in 2019, and on the right-hand side is 2020. So practices are averaging the control of blood pressure was pretty good in about 70% of practices, but you can see there was some variation shown by the green arrow between them, but they were getting up to a kind of reasonable level. You can see they should have, some people were already at 100% or 80%. There's room to improve further, but nevertheless they weren't doing awfully. They weren't below 50%. Now look what happens back in when people are stopped coming for their blood pressure recording. So these are slightly misleading figures, because it isn't that people's control has actually decreased. It's the fact that they're simply not having their blood pressure recorded, and you get the average then falls to 50% because you're counting anybody who hasn't got a record as being out of control. That isn't entirely true. So having understanding data is quite important, because the story here isn't that the control has got worse; it's the fact that people aren't having their blood pressures recorded. So here's a data that we've produced for people under 80 and the lower things, and over 80. So the over 80-year-olds, the older people, are having their blood pressures measured a bit more frequently than and the people at younger ages, which you'd expect because they come and see their doctor more often. But you can see how in sort of the end of 1920, this drops off the cliff, and it falls right down with lockdown as people aren't having their records, and then there's a slow increase. So it's about how we can sort of further improve that restitution of services. So we need to use the right method, and this is a point that we need to understand, which is that the prevalence of disease, how many people have heart attacks, how many people have strokes, are determined by factors outside of general practice. And it's very difficult to compare practices unless you can kind of standardize for all the factors that apply to that individual practice. So that a practice in Lower Clapton might have a very different population from a population in Stamford Hill, for example. Here, this is the level of the proportion of the people who have hypertension. And you can see that some people got lots more people with hypertension at the top, and down the bottom there's a fewer. But so there's a lot of variation between practices, but this isn't because practices are failing to detect people with hypertension. It's because the populations differ hugely, and you get situations, as in say Bournemouth, where the population is much older, and so of course there'll be many more people with hypertension than compared to City and Hackney, where it's a much younger population, and so on. So unless you control for all these things, that you can't, it's very difficult to compare practices for prevalence of disease. And even when you standardize for age and multiple other factors, the use of this funnel plot isn't the best way to describe outliers. These are outliers because of factors beyond the practice itself. And there's a thing called over-dispersion, which also leads to these type of charts being incorrect. You can use them correctly, and this is one which is using, it has to be Haringey, but it was using the proportion of people on anticoagulants, and you can see at the top that some practices are doing very well. They've got 100% or nearly over 90% of their patients on anticoagulants, and down the bottom are some practices. So you might want to look at this practice here, down at the bottom left-hand corner,
And it might be of interest to you to know that that's the homeless practice. So you might expect that, so it's not because that practice is performing particularly badly, but it's because it's got a particularly challenging population. So understanding, data is quite an important thing. And then I want to talk briefly about inequality indicators, that we need to include inequality or equality indicators as standard at a CCG level. You can't really do it so easily at a practice level because the numbers are too small and the populations are too different. But we can at a CCG level look at, is there equity by age, by sex, by ethnic group, by deprivation, and for vulnerable groups such as the housebound, homeless, or people with learning disabilities. So, we need to kind of build that into our work. So this is showing that same data I showed you on hypertension with reaching targets. And the green group are South Asians who are doing slightly better than the white group, which is in orange, and then the black African Caribbean, the black British group are doing least well. And that factor's been the same before and after the pandemic. It hasn't altered substantially, but it is a known factor that, we have particular difficulty controlling the blood pressure in our black populations. And that's an issue that needs to be addressed. Here's a picture which is showing you this index of multiple deprivation, which is a measure of disadvantage for all the CCGs in England. And we're looking at a particular measure which is used in the national QOF measurements, which is having your cholesterol controlled below a certain level if you've got diabetes. And here we've got City and Hackney in red, Tower Hamlets and Newham are all sort of up in the, well, they're the best in England. But the point about it is that they're about 10 percentage points above the average in red. And but that's above the average. If you compare it with similarly deprived areas like Blackpool or whatever, it's more than 20%, almost 15-20% above. And that 20% has a huge impact in population terms, in terms of saving lives from stroke and heart attack and so on. So that's a really, really big, and it's all the more remarkable because City and Hackney is a very challenged area in many ways because of the deprivation and so on that we're dealing with. And then the last point I want to make is that the greatest impact is where there are the biggest numbers who you apply the most effective treatments to. So applying things to very small numbers of people doesn't give you much impact. And I want to sort of just give you the McKinsey model, which is the hospital model, which has dominated thinking for a long time in the health service. And they say, look, all these old people are with complex health needs are using up all the hospital beds and costing us all this money. And we ought to concentrate on this group, as the sort of single most important thing to do. The problem is that we don't really have very much evidence that we can make any big impact on reducing hospital admission in these people or reducing their death rate. And if our sort of model of impact sort of only has a few people at the top of this pyramid, and our intervention is not very effective, we're not going to have much impact. So if we have 100 people up there in that group, and we have a 1% change, we're only going to save the life of one person. Whereas if we move down the pyramid, where we've got many more people and we've got more effective medical interventions, we've got the control of blood pressure, the control of people's cholesterol with statins and so on, well, we can have an impact on 100,000 people and make a 1% change. And then 1% of 100,000 is, at least 1,000 people. So, you can make a much bigger change. The other problem with this hospital measure is that of people who are 80 years and older who are admitted to hospital, almost 40 or 50% are dead within a year. So what you're doing is targeting people who are dying. It's not an effective way to reduce mortality. It might improve the quality of their life, but it doesn't reduce hospital admission. If you want to reduce hospital admission, we've got to look at other ways of doing palliative care and managing people at home. And that's an issue that has completely been failed to address by successive governments. But it's about kind of looking at this middle part of the pyramid is much more impactful, and also population health and prevention. I just want to show you a couple more figures that we've
City and Hackney has done particularly well on. This is the optimization of giving people high intensity statins if they've got a heart disease, and City and Hackney in red and Tower Hamlets are both. These are all the other CCGs in England, and there's only one other CCG which is better, which is in Bradford. They did something pretty spectacular up there, but it's just to show you how far above City and Hackney is above the other organisations. So my kind of closing bits are that we need to look under the light at what we need to do and choose wisely. First of all, we know that adult immunisation for COVID and flu is absolutely essential, but we have seen our childhood rates of immunisation fall rapidly, and I can tell you that we will almost certainly have measles epidemics in the next couple of years, because we are now way below levels. We never ever achieved the 90% WHO level, and most London CCGs are now around 70%, but that 70% average conceals localities where the measles immunisation rate is below 50%. And do you know what the R value is of measles? Well, you will remember, I think, that COVID was talking about 1.2, 1.5, maybe 2. Measles is 18. So you can guess what happens in low areas of immunization and what's going to happen next. The next thing to say is that CVD is the most ameliorable thing, and that anticoagulation for people who've got atrial fibrillation, control of blood pressure and statins will have a bigger impact than anything else you can do. And lastly, we are the renal failure capital of Europe in London, and in particular in East London, because of our big immigrant populations, and we can do much better to identify and target renal failure. And then there's a question of medicine safety, reducing bleeding, reducing hypoglycemia. Those two things are the commonest cause of admission to hospital for adverse events, and we really don't address safety in primary care in the way that, say, sepsis has been identified as an issue of safety in hospitals, and the reduction of the sedative load in older people is an outstanding issue. So what we need to do is to agree on our key deliverables. We've got to make childhood immunization a key deliverable, control of blood pressure a key deliverable, and align commissioners, practices and incentives around that. Prioritize the highest risk groups and find the people with highest blood pressure and make sure they're controlled, and the equity issues for the Black African population or other population groups that don't really receive immunization, for example, reducing variation, choosing the quick wins, upskilled practice teams and pharmacists, and these, so that everything doesn't fall on the shoulders of the GPs, and then finally inform and engage communities and have equitable benefits and show our impact. So, I think the other thing to remember is that, like schools, it isn't just looking at the people. This is proportion of people with a pulse check over 65. And you can see that some practices are in green are doing really well. They got sort of 95%, but it's these practices here who aren't up there, but who come the furthest. So I think that, understanding that targets, are pretty crude measures, and that actually you want to incentivize change as much as, absolute achievement. We need both those things. So I'm going to leave it there and see if I can unshare my screen.
John, you're unshared already. That's fascinating. Thank you very much.
Right.
Can I move on to Malcolm from Healthwatch? Malcolm, can you give us a brief overview about what do residents think about GP provision in Hackney?
Okay, I'll try to be brief. I suppose the sort of things that we're hearing from residents are not particularly unsurprising. Not particularly surprising. That is that face-to-face consultations have diminished substantially, and people are quite worried about that, although that's starting to increase again. That I think that the other thing sort of brought in is about non-clinical triaging, which people sort of quite concerned about the fact that they're being triaged by non-clinical staff. And that often feels very unsatisfactory to people. The receptionist is triaging, and they're sort of thinking, why is this happening? The digital divide that's already been mentioned is a very serious matter. And somewhere like Stamford Hill, where large numbers of people don't use, especially women, don't use the internet, is one of those examples. you know, we're going to be doing quite a lot of enter views. That's one of the statutory powers of Healthwatch, to sort of go around to practices over the next over the next 3 years to really sort of hear the voice of local people about their experiences of primary care. That's going to be important. But the other really important thing, which was mentioned, we discussed last time, but really needs to be dealt with, and that is the current situation where Southgate and Worcester Road are closing, with 6,000 patients being transferred to other practices. And I'd be interested in what Deborah has to say about this, because the impact on Lawson, or the Lawson practice, must have been absolutely huge. And I think that's really worrying, that GPs are having so much pressure put on them as a result of practices closing. And we have to find a way of making sure that there is a proper process to stop practices closing down, a proper process of bringing in new partners so that these practices can develop, instead of ending up with the APS-based practices, which are often somewhat difficult. We want to see much stronger PPGs. You know, one of the real issues that people talk an awful lot about PCNs, about neighbourhoods. Most people haven't got a clue what they are. I mean, there's very little communication about PCNs and neighbourhoods are, and people, when we talk about them, people sort of just really wonder what we're talking about. The idea of increasing the number of practitioners in a PC area is a great one, but often patients don't understand why they've been, why would they be seen by a paramedic? Why would they be seen by pharmacists? These are obvious to clinical staff, but to patients are often quite obscure and not very well understood. Just sort of a couple of other things is that we did, thank you very much for the excellent letter that was sent to the CCG about practices which are not registering patients in the right way. I think the exchange between ourselves and the CCG on this has been outstanding. We have to make sure that all practices are registering those patients who have a right to be registered, which is all patients. And the very idea that some patients are excluded because of factors to do with their right to be in the country, what sort of data they have to demonstrate their rights is totally unsatisfactory. But we also got to look at the secondary care, for example, long COVID, and how people long COVID who don't have regular status can receive proper treatment. So we'll be carrying on with those kind of surveys, also looking at the websites. Some of the websites, a lot of websites are pretty excellent, but some of the GP websites are not good enough. And one practice manager told me recently that she finds it difficult to use her own website. So we really have got to look very closely at that. And just a couple of last things, and that is, one second. What was I going to say? Yeah, just one other thing I just want to mention is within a PCN area, why is it not possible for patients to register any practice within that area? Because it seems quite odd that you can be in a PCN area, but actually you can't necessarily register with all of those practices. And it just seems irrational and illogical that patients don't have the right, that have more choice. So I think that's all for now. Thank you very much.
Thanks, Malcolm, and thank you for your work about highlighting the access issue in terms of passports. I think there's certainly some progress made with one practice straight away, but hopefully with others as well.
Sorry,
can I then pick?
There is the complaints charter for GPs, which we produced not very long ago, which I'm hoping will be available to patients throughout every GP practice. That's all I'll say. Thank you.
Thanks, Mark. And just to pick up then on the point, which nicely leads into Richard. Richard, could you just spend a couple of minutes explaining the process when and this is item 7, when a practice either doesn't want to renew its contract or a partner retires? What's the process you go through in terms of list dispersal or finding someone to take over that practice?
Yes, I'm very happy to talk about that. So, we're equally concerned, as everybody else is, about the number of practices closing in City and Hackney. We've had 4 closures over the last 4 years. Salisbury closed because of a failed APMS procurement. We couldn't find a provider to run the practice. We did find one provider, but they had to drop out. The number of patients there was just not enough to make the practice viable. Abney, the sole partner there, handed back his GMS contract due to pressures of work, including the additional services that the CCG commissioned. He didn't avail himself of that population cover and which the GP Confederation provide. So he didn't have to provide those enhanced services, but he felt he did, and he handed back his contract. Wick branch closed. That's reasonable given that it was run by a very senior GP. Dr. Osen Senior, who was in his mid-80s when he retired, so that was the cause of that branch closing. So I don't think there's anything we could have done to stop that from happening. And then Southgate Wiston is closing most recently, and that was triggered by the two remaining GP partners there handing back their GMS contract. We take each situation on its own merits. We do have an established process for determining what we do in these situations where somebody hands back their contract or the point in which a contract is expiring, and we do take that decision, that case, through the proper governance channels. So we have an established non-conflicted primary care commissioning advisory group in City and Hackney. We have an independent GP advisor on that. We have Healthwatch on that. And we present the case for either dispersal, as in requesting that the patient registered with that closing practice register elsewhere, or that the contract is offered to the market. We offer that contract on a new APMS basis. And then that decision is ratified again by North East London Hub of Primary Care Commissioning Committee. Now, the decision we come to, whether we disperse or whether we reprocure, we take lots of factors into account. We look at the list size, both raw and weighted. We look at any current contract expiry date, the contract type, the reason for contract expiry, whether the contract's already been extended beyond its natural term, whether there's provision for any further contract extension, the background, the whole history of the practice. We go into the deep dive into the current practice performance. List size considerations. So Malcolm wanted to know what the impact was of Southgate's closure on Lawson. We do an analysis at a very early stage of what capacity there is in the local area surrounding the practice. So we draw a radius a mile wide around the index practice, the practice that might close, and look at the number of practices within that radius and what capacity they have to take on new patients. So that's the sort of capacity audit that we do. We look at the potential for list growth to see whether actually the practice could ever be viable over time if it's currently serving less than 6,000 patients. And interesting than tell us that any practice below 6,000 patients is economically unviable. That's not the natural trigger then to say, okay, we will disperse. Again, we look at every single situation based on its own merits. The factors I'm talking about here. Premises considerations, very important. If we don't have guaranteed premises for the practice over the life of a 15-year APMS contract, that puts us on a very shaky footing to go out to the market for a 15-year contract, which is what we want to do under APMS. Demographic considerations, or all manner of wider strategic considerations. So all of that goes into deciding what we do when somebody hands back their contract or a contract is expiring. A lot of thought goes into it.
Thank you, Richard, for going through that. We are chasing time a bit. I've seen Councillor Gregory who's got her hand up. So what I'm going to do is I'm going to take Councillor Gregory's question, and then I think I may have to draw this to a close so we can move on to the pharmacy item. Councillor Gregory?
Yes, thank you. I want to go back to the digital divide issue because I want to raise the fact that a lot of elderly people can't even use the phone, let alone the internet. So my personal experience is that my parents couldn't use the phone, and so for 25 years they didn't ever go to the GP because they couldn't make an appointment or order a prescription because of the way the computerized system works. So I used to help them out, and then last year when my mum phoned me a couple of times when she couldn't call an ambulance because she couldn't work out how to use the phone. I was really pleased that I was able to call an ambulance from London to get her an ambulance to Aylesbury to go to pick up my dad and take him to hospital. So I think that's a good innovation, and I wonder if you have any other ideas for good innovations that could help people. And then I just wanted to pick up on what Jon Robson said about 40% of people who are over the age of 80 die within a year after going into hospital. I still think that 60% who survive is a good figure. And I particularly felt, again, a personal story, that when my dad went into hospital last year, considering he hadn't had any GP services for most of his life and he got a bit of treatment, I think he deserved that. And even if he hadn't been seeing the doctor regularly, I still think he deserved that chance equally. Thank you.
I completely agree with you, Michelle. I wasn't suggesting that they shouldn't have anything other than their equal and chance according, to whatever need that they've got. But it's just that if your services are entirely focused on reduce in that kind of way, then rather than down on the pyramid, you won't have as much impact in general on the population. But it is true that and City and Hackney has been leading on this, providing additional services for people with complex needs, which I think is fantastic. Absolutely.
And Kirsten, can I just go to you then finally in terms of further suggestions on digital divide, which Councillor Gregory was mentioning?
Yeah, I mean, I wanted to end on a positive note. The first thing I want to say is it's definitely on our agenda, and we are doing a lot of work. I'm trying to do a lot of work across the borough, through the CCG, through PCNs, around inequalities, and it's certainly on our radar. And we are looking to work on that with all practices around this. So there's no easy answer, but we are. It's definitely a priority for us. I also want to highlight the fact that in City and Hackney we have contracts like the proactive care contract, which Laura mentioned earlier, which is exactly for these vulnerable patients who we give dedicated time to these patients. We go out proactively and visit them in their homes. We offer, for those that come to the practice, proactive care appointments for exactly this reason, to try and reach those patients that really need it the most and give them the time that they need. And this is something we do in City and Hackney, which is not done elsewhere. And it's a wonderful service. It's our patients really value, and it means that we can get in before they get poorly. So I think we need to recognise that. I also think that on Malcolm's point, yes, we need to work more with our patients. We need to communicate better with our patients about different services. We need to engage with them on how to provide our services, and we are working towards that. And we have a wonderful volunteer project which is working with practices around some of these areas, around engaging with patients, making them feel part of the practice, and looking to make our services better and improve the care for all our patients and the population in City Hackney. So there's lots to do, but I think I just wanted to end on a positive note that I think our GPs are doing an amazing job, and in really, really tough circumstances.
No, thank you. And I think it's very clear from what's been said. We've known for a long time. We're very lucky to have the GP cohort we do in Hackney, and we're all very appreciative for the tremendous work you do. Eleanor, last word to you in 15 seconds if we can. You're on mute.
Sorry, thank you. Yeah, just very quickly in response to that last comment from Councillor Gregory again, is that I think our hope is, certainly in my practice at Nightingale, is actually that the advance of online access will hopefully improve the access for those who struggle, because it will free up the phones, and it will free up them. Now our doors are open again at our practice. So the people that, if we can get everybody who can to use online, and then people who can only use the phone can get through, and the people that need to come to the practice because they're hard of hearing or they've got learning difficulties, it's easier for them because everybody else is using online. So it's something certainly on a practice level. Every time that we think about digital innovation, it's making sure we also have those other options that hopefully then are actually better for it.
Thank you all very much. It's been fascinating and very helpful to learn, see the full picture. And there's several areas where I think in due course we can maybe follow up, maybe in a year or so's time, to understand where the PCNs are up to. Thank you all very much. As I said, yeah, we certainly do recognise as representatives, and we have done for a long time, how lucky we are to have the system we do have. So thank you very much, and thank you. Please don't, everyone who's been there for that main item, please don't feel the need to stay for the pharmacy item, but you're more than welcome to, because there is some overlap. So item 5 then is to do with the dosette boxes that the pharmacists provide. As I understand it, we've got Yogendra Parmar, who from the Pharmaceutical Cttee, and Rozalia from the CCG here. As we understand it, the funding's essentially been coming to an end now to provide those dosette boxes, and there are concerns raised with that. Yogendra, can I go to you first to give us an outline of the issues?
Of course. So as I sort of outlined in the paper that we submitted, if effectively, the production or dispensing of medicines in blister packs is often seen as a panacea, but a very imperfect panacea, and that pharmacies are in the main put in a fairly invidious position where there isn't much national funding, or if any, for the provision of medicines in blister packs. It's only for those that qualify for a reasonable adjustment under the Equality Act, and in the main, the requests for these blister packs is from carers and formal or informal or care agencies, which isn't funded through the national contract. The NHS England scheme was inherited by NHS England from the PCTs, and was designed to fund that gap, and has continued for a number of years. Our concern is, as outlined in the paper, that the local system is designed around that's predicated on that service being available, and medicines being supplied in blister packs accordingly. And NHS England has signalled an intention to terminate that service, but there isn't an impact assessment being produced, and we're concerned about the potential impact of any precipitous decision should that happen.
And just so I get the numbers here, as I understand it, there's around 500 patients in Hackney that would fall under the equalities framework that you might accept, that should be 580 maybe. Look at the exact figures that you accept, that you're funded to do under the core contract to provide it, but there's about another 3,000 who you are then the top up money was provided for. Is that roughly right?
Approximately. It's tricky to put definitive numbers to it, simply because they're individual cases, and they need an appropriate assessment. But I wouldn't contest those numbers necessarily. I just don't have the I can't give you definitive percentages.
Can I just be clear? I mean, in a way, what are you asking for, or what are you suggesting? Because as I understand it, the rest of London has moved from a position whereby this has been taken away. Hackney, Camden, Islington hasn't. I mean, are you suggesting that, say, the local CCG or GP should backfill on this, or the NHS England just shouldn't be cutting it?
So it's a tricky situation, because in the boroughs where it's not funded, it's a mixed economy, in that often the blister packs are funded informally from general practice via 7-day prescriptions in the main, and so we can't really compare benchmark our areas against others, because there is a mixed economy in other areas which informally funds the provision of these boxes in these circumstances.
So I'll bring Rozalia in a minute, but is it the case then that, so say this funding stream comes to an end by NHS England, a crude way, and I'm not suggesting your work should go unremunerated, but a crude way for then you to get paid for what you do is to require a prescription every 7 days, because via that mechanism, you get paid for the work that you're doing. And so you can pull that lever and enact that to make sure you get paid for what you're doing. Is that roughly right?
That is a very crude way of doing it, yes. There are other ways of funding it, and arguably, push comes to shove, would be charging patients for it, but often that's anyway.
No. I mean, I understand how hard work. Yeah, and government funding streams offer something for a few years, then take it away, and then expect professionals to absorb it in their day-to-day business. So, Rozalia, from the CCG's perspective, have you got any observations? I appreciate in some ways you're stuck in the middle here, because this is obviously an NHS England London decision, and then you're left to pick up the pieces as the consequence of it. I mean, what's your view on the pharmacies backfilling the work they're doing via the 7-day prescription method?
Yeah, if I can come, could you hear me, by the way? Okay.
Yes.
Great, thank you. I've got these new headphones and I wasn't sure. I agree with the vast majority of what Yogi has summarized in terms of this service was set up. It was the funding, which was about 800,000, was transferred to NHS England, and then in 2018 was the first indication from NHS England that they had done a review, and they had come to the conclusion that they wouldn't continue the funding for this, partly because they felt that some of the funding was held in the global sum for community pharmacists, and partly because they felt the service wasn't sort of fit to continue, and also that they didn't commission things on a borough by borough basis. They either did it across London or not. I think there were 5 boroughs that had a service at that time. 2 have been decommissioned, including Wandsworth, and I don't understand whether. I don't know the detail of what, if anything, was put in place. My understanding is there wasn't anything formal put into place. We have been pushing back on NHS England to hold back on the decommissioning, to allow pharmacists more time and practices to kind of work on this. And we've managed to do so that it's been extended to March 2021, September 2021, and then now. My understanding from the LPC is that pharmacy providers have not been given a formal notice. But when I spoke to NHS England this week, they were of the view that they have issued such notification, and they would be here in April to be able to give further information. We took it upon ourselves in the CCG to start to facilitate some of this, even though we're not the commissioners. So last year we had a small group of practice support pharmacists that we tasked with looking at the data from NHS England, which at that time suggested there were about 4,000 patients on the scheme. But looking further into the data, a not insignificant amount of patients, I think there was just under 300 patients, had either passed away or no longer living in City and Hackney, but were on the NHS England register of costings. The 580 patients you mentioned were those who are already having 7-day prescriptions, and also on the NHS England scheme. As Yogi mentions, that in a crude way, community pharmacists are willing to accept 7-day prescriptions as a way of subsidizing their efforts in filling dosette boxes, and we should acknowledge that they can be actually time consuming to complete. The actual boxes are fairly cheap to obtain. I understand it's about 20 pence, but it's quite time consuming if you fill it in properly. So we've developed guidelines on the back of the project we did. We developed guidelines for GP practices and community pharmacists to be able to look at a way forward for those patients who would need a dosette box. Some patients we felt would fall under the DDA. This is where myself and Yogi probably diverted position. The LPC on behalf of community pharmacists feel most patients now don't fall under the DDA, and that there should be 7-day prescriptions.
Just so everyone's following, what we mean by that is that they don't fall under, say, what should be funded by the core contracts.
Yes.
And so fine. So there's around, fine, okay, carry on. So
so 580 of these patients are already getting 7-day prescriptions from their GPs. We consulted with GPs and the LPC about this guideline. We thought we had reached a unified agreement last year, but we subsequently, I think, had feedback from the community pharmacists who fed back to Yogi that they would like some wording change. So we're doing another version of the guidelines, but we hope that these guidelines would help to mitigate some of the circumstances, because it would indicate that the community pharmacists would do the DDA assessment, and if they felt that the patient wasn't DDA compliant, have discussions with the GP practice to share why they feel the patient doesn't fall under the DDA, and then the practice could then agree or not to provide 7-day prescriptions. And that's where we've come to a bit of an impasse, because the committee pharmacists, some of them feel a lot of patients don't fall under the DDA, and for some practices they feel most of the patients fall under the DDA, and so they shouldn't be required to give a 7-day prescription. I think kind of halfway between this position. I can't formally sanction that GP should give 7-day prescriptions, especially as NHS position. The formal national position is that 7-day prescription shouldn't routinely be used to fund dose set boxes. It's routine. It doesn't say you should never do it, but it says you shouldn't routinely. And then a last bit I wanted to capture. I'm sorry, I know I'm speaking a lot and very fast.
No, it's all right.
You can let me know if I need to slow down. I sometimes go too quickly. But one aspect I want to kind of raise here is there is a huge misconception that having a dose set box makes patients compliant. And it doesn't translate as such. I, for example, am very forgetful about taking my food supplements, vitamins. If I forget the whole lot. It's not about I forget one or the other. I do recognize there's a role for them, for those who are on complex medication schedules, where this might meet it. But there's a whole list, there's at least 30 issues flagged up in national guidance, in NICE guidance, in CQC guidance, in the specialist pharmacy service, which is commissioned by NHS England. There's a CHUM study that errors can go unnoticed when it happens through dose set boxes. So if I can just name a few of the issues, manufacturers don't necessarily, their license doesn't necessarily allow you to manipulate the medicines and popping them into another container. That's partly because they don't have stability data for it. So for example, aspirin that you'll be familiar with, it comes in a dispersible format. Often found in dose set boxes, it's hygroscopic, it absorbs moisture and destabilizes the medicine. So by doing so, you might be reducing the therapeutic effect of medicines. The size of the medicine makes an impact. Some medicines can't easily fit it into dose set boxes. The National Reporting and Learning Scheme, which captures errors that happen in the NHS, in 2018 identified 507 incidents associated with dose set boxes, and that would represent an underreporting. There's huge amount of underreporting, particularly in primary care around medicines issues. There have been patient deaths because certain medicines like methotrexate have been popped into dose set box and they're high risk. Patients are often not assessed appropriately to assess whether a dose set box meets their individual needs. Often dose set boxes are overused. There may be patients who need a plain cup because they can't open a childproof container, but they're having problems with adherence, and someone says, give them a dose set box. It doesn't necessarily address that because they'll still have dexterity problems.
So in other words, what you're saying, there are numerous examples whereby
huge amounts of overuse. Huge amounts of overuse. Oh, sorry.
Because we know, just because we're running out of time, can I just bring Yogendra back in for his observations, and then maybe draw this to a close? If I'm trying to think of whether there's any way we can take this forward.
Thank you, and I fully acknowledge that providing medicines in blister packs is not ideal, and I would much prefer for us to be supplying medicines in original packs. But in reality, the systems that we have around us are generating demand currently for the blister pack medicines. And currently, if the NHS England scheme isn't in place, that would be an unfunded supply, which would be unsustainable. And the reason for bringing this to this forum is to highlight the potential risk to the patient's care, given that there are care agency, the local authority care contracts, and other facets of care for patients. What none of us would like to see is a precipitous change or an unmanaged change in these patients' care.
Certainly, I'm certainly prepared to write to NHS England London and express our concern in terms of the impact upon and the risk to patients if this isn't resolved. But I suppose I would just encourage as a way. I mean, I have a great deal of sympathy with the the pharmacists, essentially, if they're being asked to carry on doing work they were previously funded to do, and whether there's any mechanism. And but I also appreciate extra work on GPs if they're being asked to provide further subscriptions. But if there's any way that some sort of local agreement could be reached as a halfway house, I don't know. But I mean, certainly I would. Go on, sorry, do you want to...
No, and that's what we're working. Working with. We're working.
Well, I mean, it was certainly if you can, because I do have. I think probably all of us here have sympathy on.
Yes,
on both sides.
Absolutely, and the problem is if they are, as Rozalia suggests, going to stop this service at the end of the month, then there's going to be a lot of conversations being had at a very at scale and pace.
Yeah. Okay. I think certainly I will certainly echo the concerns to NHS England London, and we can write. And I urge sort of the local, the local framework, which generally works very well together, to see if there's a way that can appreciate the work the pharmacists do. But also not wanting to overburden GPs. If there's a practical, common sense, lateral thinking way through this that achieves that, I would support that. I'm going to draw this to a close. Thank you both for alerting us to it, particularly bearing in mind the number of vulnerable patients could be affected. Can I draw that to a close then, and thank you both. Can I, for 3 minutes, Chris, can you just give us an update? I was hoping it was going to be the end of our COVID updates, but sadly, it looks like we're on the uptick again. Chris, over to you.
Yeah, I'll try and be as brief as I can. So the information that we had submitted as part of the papers was for the preceding week, and that was continuing to show the gradual decrease in numbers from a very high base, still quite a high number each week. There has now been a very strong about turn in the figures, and that's why I really do want to present this to you. So it is only 1 week of figures, but it is against a background of really significant increases across Europe and also across London. So in London, we've had a 49% increase in the number of COVID cases of all ages, and for the 60 plus, a 51% increase in COVID cases. Now for Hackney, that's a slightly lower increase of just over 30%, but it is an increase across all ages. So this is the latest data that you can find on our council website. And you can see that the increase has actually occurred in the last week across all ages. And again, that's fairly similar for across London. Now, what the living with COVID, the two messages really is that vaccination has broken the link between large number of COVID cases and hospitalizations. And the other data that perhaps hasn't been able to be presented as strongly in the news because of other world events is actually that the hospitalization rates, again, 1 week's worth of data, but there are now some really strong signals that actually the hospitalization rates are going up. Now, the reason why we think that might be the case is partly because of the natural immunity. It doesn't provide you with particularly effective protection against serious infections from Omicron, but it does provide you with some. And also the fact that the booster vaccinations for a number of people, we are now towards the end of where that really good immunity from the vaccination provided you with protection against hospitalization. So we are seeing large increases in hospitalization rates as well. And I think the vaccinations obviously have significantly eased as well in terms of people coming forward for vaccinations. We probably only have 1 or 2 weeks worth of data before we will, if the government continues with its plans, end the mass-free testing, and then we will be down into a much lower level of ability to track the epidemic, and it will probably be mainly through hospital admissions and then the REACT ONS study. So the key message from public health at the moment is that the end of the COVID regulations and the welcome end of many of the requirements to legally self-isolate is not the same as what we would say has been the message that's been crowded out around actually the COVID measures that need to be continued beyond April, although there won't be mass-free testing, around mask wearing, ensuring people get the vaccination, a degree of social distancing, hand washing and ventilation. So if these figures to continue, they are signalling a very, very unwelcome change of trend. And I suspect, unfortunately, that the national focus at the moment is elsewhere. And because we have given so much emphasis on the ending of COVID arrangements and the move to living with COVID being a more of a personal choice, that actually we may be stoking up significant difficulties for us over the next few weeks.
Thanks, Chris, for that update. I don't think, unless there are any questions on that, I won't take any because we're running. Vinay Panel says, is this a new variant? I mean, there's been talk of, is it BA2?
Yeah, so at the moment, I mean, there are new variants there all the time. WHO will classify variants of interest. We haven't had a recent variant of concern that's come across into certainly the UK. What we do have is a sub-variant of Omicron, BA.2, which certainly is easier to transmit. And obviously, we've also got the same time, we had people coming back from half term, and we have significantly larger numbers of people social mixing, and obviously mask wearing mandate has now been significantly weakened. So most people are behaving in a way that facilitates perhaps the spread of the COVID.
Thanks for the update, Chris. I know Councillor Kennedy and the Mayor sort of signed off on a PR campaign in terms of trying to keep awareness up from a council comms perspective. Thank you for the update. With that then, because we're slightly overrunning, I haven't been notified of any other business. I'll thank everyone for a very interesting meeting and draw it to a close. Thank you, everybody. Thank you.